technique of radical cholecystectomy in a 56-year-old male with a resectable gallbladder mass of the fundus in the proximal body. This image depicts what is now our standard placement for all major upper GI procedures, namely laparoscopic choledochal cyst, laparoscopic radical cholecystectomy, laparoscopic Whipple's, or laparoscopic D2 gastrectomy. So the ports are placed in this fashion. A, B, C are the 10 or 12 ports, and D and E are the 5 ports. So the surgeon has access to work from all sides. A can be the camera port, with B and C as the surgeon's right and left hand working ports, and D and E will be the assistant ports. Likewise, surgeon can work from the right with the B as the camera port and A and D as the working ports, or surgeon can work from the left with C as the camera port, A and E as the working ports. Like this way, he has access and you can maneuver from all sides in these complex GI procedures. This makes the port placement very simple, reproducible, with a lot of adaptability for various angles. After an initial diagnostic lab looking at the liver, omentum, and peritoneum for deposits, the first step involves cauterization of the duodenum and biopsying the retroperitoneal lymph nodes. Obviously, involvement of these nodes would restage it to M stage, so we biopsy them and send them for frozen section. For this cauterization, the surgeon can work from the camera can be in the midline port, or if it's difficult, the surgeon can shift to the right side and work from the right side, while the assistant provides retraction of the duodenum from the left side. With this retraction, the duodenum is being lifted up and the retroperitoneal attachments of the duodenum are progressively lysed. You can see the landmarks there coming into the view, the IVC and the gonadal vein. And once we do the external cauterization, we identify the aorta, groove between the aorta and IVC, and the retroperitoneal chain of lymph nodes in this part is being sampled. Just make sure that, especially the IVC, you dissect it well and avoid any injury to the IVC during this part. And this lymph nodes are being dissected and sent for frozen section. The next step would be to assess the resectability of the gallbladder, mainly in terms of, basically we assess the callus and the neck, lower third of the neck area, because if there is, the tumor is extending till the lower third and infiltrating the neck of the gallbladder, then we can't do a simple wedge or a segment 4B5, because the right portal pedicle would be involved, and then we would have to actually do a formal hepatectomy. So we dissect the callus, clip the cystic artery there, and once the callus is opened, the neck of the gallbladder, the lower third of the gallbladder, the neck of the gallbladder is dissected off the liver bed safely. If at this point we encounter infiltration, that means the neck is in liver bed, the neck is infiltrated, and that means the right portal pedicle is very close. So this patient, simple segment 4B5 will not suffice and need a formal hepatectomy. But in this case, as you could see, the neck was freed, and we can go ahead with a segment 4B5 or a wedge liver resection, depending on the extent of liver infiltration. So the first step in the lymphadenectomy is we go to the lower border of the hepatoduodenal ligament and divide the right gastrix and the lower border of the hepatoduodenal ligament of its attachment to the upper border of the duodenum. Obviously, at this lower border, you'll have multiple right gastric branches. We will divide all of them. And then once we identify a vessel, in this case the GDA there, which we are dissecting, or if we take off the common hepatic node, we will identify the common hepatic artery there. And once we identify the artery or the node, that forms the sort of roadmap for our lymphadenectomy. We travel on the surface of the vessel and clear out all the lymphatic tissue, and walking on the vessel is the most efficient way to do the lymphadenectomy. So that's the gastrohepatic omentum being divided. That's the common hepatic artery, lymph node being dissected and lifted off. Once we see that, we can see the area where the common hepatic artery is dividing into the proper hepatic and the gastroduodenal artery. Once we identify that, we work on the surface of the vessel and progressively now we are dissecting of the fibrofatty and lymphatic tissue of the left hepatic artery and the proper hepatic artery. You can see the proper hepatic artery there dividing into the left and giving off the right hepatic artery, and the it's being detached of the left lobe hilum also. At this point here you can see the so here now we are dissecting between the in the groove between the hepatic artery and the bile ducts, separating them progressively. Then we can identify the right hepatic artery there. So it's always important to have your exact bearing as to the right hepatic artery. You can see the right hepatic artery there. Once that is done, we are continuing the dissection on the surface of the left hepatic artery. This is actually the proper, and the proper is later on is dividing into the left and the right hepatic arteries. That's the right gastric coming of the proper hepatic, which we are redividing as we discussed previously, and subsequently the fibrofatty tissue and the lymphatic tissue is detached of the umbilical fissure. Then once this dissection is done, the dissection progresses from a medial to lateral fashion from onto the common hepatic artery we identified there. We are now traveling on the common hepatic artery towards the celiac origin. Again, like I said, once the vessel is identified, the best plane and the most bloodless plane of dissection will get on the surface of the artery. We stay bang on the surface of the artery and just off the adventitia, and lift off all the fibrofatty and the lymph nodal tissue. As we progressively dissect, at some point we'll have to detach the hepatoduodenal celiac chain of lymph nodes from the retroportal nodes, because they will be taken when we do the retroportal lymph node dissection. It's not possible to take the whole thing off in one chain, not convenient to take the whole thing off in one chain. So we detach it there and then first complete the lymphadenectomy along the now we are at the celiac origin. We use the left gastric as a marker there. The lymph nodes of the common hepatic, the and right side of the celiac origin and the common hepatic lymph nodes are all being cleared here. This is very patient dissection. One more structure which we should avoid injuring here is the coronary vein. It's better to identify it and clip it neatly because it can tear and cause troublesome bleeding. That's the lymph nodes and the lymphatics over the left gastric artery, which sort of indicates that we've reached the lateral end of our dissection onto the celiac origin. So progressively the nodes at the origin of the left gastric nodes, the common hepatic and the nodes of the celiac origin are being divided, and the lymphadenectomy on the left side is completed. The last part of the gastrohepatic omentum is being detached. All this lymph nodal specimen is placed in a specimen bag. Also identifying the portal vein there, lifting the tissues of the portal vein. And once the portal vein is defined, we can dissect the lymph node and the lymphatic tissue within the hepatoduodenal ligament between the common hepatic artery and the bile duct, the lymph nodal tissue. Again, all this decision has to be very meticulous. Make sure that you don't accidentally injure either the hepatic artery or the bile duct. So it's just like we're doing here. Just define your structures well before dividing them. There is usually some nodal tissue between the hepatic artery and the bile duct that is cleared. Subsequently, the portal vein is being defined here. And once we define the portal vein, all the fibrofatty lymphatic tissue on the left border of the hepatoduodenal ligament is being cleared till the liver hilum. And previously, where we divided the hepatoduodenal ligament chain, that is all being cleared off the portal vein. You can see all the retroportal nodes are being taken off, and then this specimen will be extracted from the right side. So on the right side, the last part of the lymphadenectomy, we are creating the retropancreatic lymph nodes. You can see we get bang onto the pancreatic surface, and the posterior superior retropancreatic nodes are being cleared, staying on the pancreatic surface. It's again very important to gently dissect and then divide here. You don't want to injure the posterior pancreatic capsule. Sometimes you can have troublesome bleeders from there. So take your time, dissect it off the posterior pancreatic capsule. You can see the posterior pancreatic capsule being bared there, and then progressively go on to the retroportal lymph nodal tissue on the right side. So for this, assistant holding the junction of the neck and the cystic duct of the gallbladder and flipping the cystic duct medially is extremely useful. We identify the surface of the portal vein gives us the main landmark, and once we identify it, the dissection proceeds fairly easily. All the retroportal lymph nodal tissues of this side are dissected, and the specimen is on the opposite side is also delivered onto this side, and that completes the retropancreatic and the retroportal lymphadenectomy. Again, working on the portal vein surface and working on the hepatic artery surface is what makes this lymphadenectomy very safe and simple. So this is the extent of lymph node dissection in gallbladder cancer. The retroportal nodes have been sampled here. The posterior superior retropancreatic nodes, the retroportal nodes of the bile duct and the portal vein are bared, and in the hepatoduodenal ligament, the nodes between the artery and the entire hepatoduodenum is cleared of the anterior tissues, posterior and lateral tissues, and also the nodes between the artery and the bile duct are cleared. And this is a celiac dissection till the celiac origin. To the right side of the celiac origin is cleared. All the lymphatic tissues are cleared until the liver hilum. You can see the proper hepatic dividing into the right and left. Again, the special attention is paid to the pancreatic capsule there. Sometimes you can have troublesome bleeding there. Just make sure that there is no bleeding. Once that is done, we proceed with the liver resection. In this patient, we planned for a 3 cm wedge of liver. The wedge is marked all around. The most important thing in this wedge is that as you go down, the wedge sort of you have to taper it down. It's like a reverse pyramid, and it tapers down towards the neck of the gallbladder. You don't take the wedge all the way till the hilum, because the portal pedicles will come there. The marking you've seen here. Subsequently, this we using the a Foley's is placed at the hepatoduodenal ligament in this way to use for a intermittent Pringles if needed during the parenchymal transection. A stitch is taken on the liver parenchyma. Retraction. Majority of the dissection will be done from the medial side, that is the segment 4 side. Initial incision is made with diathermy and ligature. Once we go beyond the first 2 centimeters, we do the dissection with the accusa, and if there's any once we do the dissection, if there's any smaller fibers, we would divide them with either diathermy or the ligature. But here what we'll mainly encounter is the Glisonian pedicles into the segment 4 of liver. You can see here that's one Glisonian pedicle. Depends on if you do a segment 4 B5. You can see in another video in our channel, you'll actually be going with much more laterally, so then you'll find really thick pedicles and fewer pedicles. As you go medially, because they branch, you'll find slightly maybe 3 or 4 pedicles will be seen. But these Glisonian pedicles should be it's easy to dissect because they're very tough, and they should be securely clipped and divided so that you don't have a post-operative bleeding or bile leak. That's another Glisonian pedicle. So we are clipping and dividing the Glisonian. So in the segment wedge liver resection, to prevent bleeding and bile leaks, a couple of things, important structures. Basically, the Glisonian pedicles in the medial part of the dissection. In the superior part of the dissection, you have the middle hepatic vein pedicles, and in the inferiormost part of the dissection towards the hilum, you identify and clip the segment 5 pedicle. This is again the Glisonian pedicles from the segment 4 side, which we are clipping and dividing. The cystic duct is now being doubly clipped and divided so that we have access to the neck of the in the region of the parenchyma behind the neck of the gallbladder. Like I said, the wedge does not go to the liver hilum. We stay about a couple of centimeters away from in the area of the attachment of where the neck is transitioning into the body. To that area only the parenchymal transition tapers down, because there you have the right Glisonian pedicle. Then if a tumor is actually infiltrating till that deep, a wedge liver resection at 4B5 will not suffice. You need to do a hepatectomy. So now as we do majority, we try to do as much as possible from the right side whenever we encountered some bleeding there. So we're doing the inflow Pringles, the Foley's catheter which we place. This is an 8 French Foley's. This is being tightened, so it gives effective Pringles without any need for any extra port or an extra instrument, and also nothing comes in our way during the dissection. As we progress into the superiormost part of this wedge, here you will see the venous pedicles. You can see there, basically you have the segment 4 and segment 5 venous tributaries which go on to form the middle hepatic vein. So these are important anatomical landmarks and structures we need to identify during the wedge resection and segment 4B5 resection, because if we actually injure them, the veins will retract and they can be fairly torrential bleeding from the middle hepatic vein branches. So with the CUSA, obviously it's very easy to identify them and dissect them and safely clip and divide them. So mainly in this superior part, you see we are trying to almost go across onto the opposite side for this superior part of the dissection. And again, any venous tributaries which if we come across, they are being doubly clipped and ligated and divided. So once we sort of cross the midline of the wedge and onto the other side, independently, of course, this is an intermittent Pringles. We are sort of doing it every 15 minutes. We unlock the Pringles for 5 minutes. In the non-anatomical resection, it's a useful idea to use Pringles to reduce the bleeding. Now we shift the camera to the right side. We're putting the Pringles again. And from the right side, the lateral side of the wedge, we are starting the parenchymal transection to join the medial transection line. Now these two transection lines are being joined together. Here mainly you might encounter some small venous tributaries to the draining into the right hepatic vein. Again, the smaller tributaries are the larger ones are clipped, and the smaller tributaries are divided with a ligature. Again, you can see as we go to the superiormost part, again another venous tributary we are able to see. Which we are clipping and dividing. Of course, this video is, I think, going at 2.5x speed, but all this part of the dissection is to be done very meticulously to avoid any accidental injuries to the veins and avoid bleeding. Now we put our focus on the in the neck area of the gallbladder, doing the parenchymal transection. Here you have to remember that you can see there the ruveus sulcus, the right posterior pedicle is going there. So you're going to have a lot of major Glisonian pedicles going in there. So as you dissect with the Cusa or with the cheliclysis, any structure that's going in, delineated on all sides, make sure that it's entering the specimen, and only then clip it. Any large thick pedicles, if you see, dissect them, make sure that it's not the main pedicle, and only then we clip and divide them. We are using the intermittent Pringles here. So what we started inferiorly at the neck and the superior, both these planes are now being joined. Like you see, the wedge, or that's another segment 5 Glisonian pedicle. As I said, identify it, dissect it all around, make sure that that's only the pedicle is directly entering the specimen, and only then clip it, so that you don't disturb the inflow vascularity of the other parts, the parts of the liver we are leaving behind. So this is a very important part of the wedge, where beginners make mistake that in the don't go beyond the junction of the bed and the neck. Don't go take your wedge onto the hilum, because once you reach there, you'll have major Glisonian pedicles, and there could be a chance of a major vascular injury or a portal vein injury. So the wedge, it starts, even it's 4B5 or it's a 2 centimeter wedge or a 3 centimeter wedge. As you sort of approach towards the hilum, stay end your transition line couple of centimeters above the hilum, and also stay away from the hilar structures. That's one last Glisonian pedicle that's being divided to extract the specimen. The inflow occlusion tube is being removed. The specimen is put in a bag. The bed is being inspected for any bile leaks or bleeding. We ask the anesthetist to fill up the patient. The bipolar is a very useful tool to do hemostasis of the liver bed. A Surgicel is placed on the liver bed, and a drain is also placed in the right upper quadrant. The post-operative recovery was uneventful. Patient was discharged by 3rd post-operative day. Biopsy was T3N1. Thank you.